This Week in Virology, the podcast about viruses, the kind that make you sick. This Week in Virology, episode number 132, recorded on May 6th, 2011. Hi, everybody. I'm Vincent Racaniello, and this is TWiV, the podcast all about viruses. Joining me today from Western Massachusetts is Alan Dove.
Good to be here.
How you doing, Alan?
Doing okay. Weather's finally nice for a day.
Spring is here.
Yeah.
Also joining us today from Fort Lee, New Jersey, Dickson Despommier.
Hello, Vince. Hello, Alan.
You sound really well, Dickson.
I feel well. It's spring.
Did you go fishing?
I did. I went yesterday, actually.
Okay. Was it productive?
It was. We had a good time.
All right. Excellent. Also joining us, we have a huge crew today. Also joining us today from down the coast in north central Florida, Rich Condit.
Hi, everybody.
How are you doing?
I'm doing good.
Excellent.
Everything's fine.
By the way, what was the outcome of the pox virus invitational?
Yes, that was won by my colleague Paul Golnick. Everybody knows he's going to win because he actually knows how to play golf. All right,
because you were leading at the turn, right?
I was. That was probably my best 9 ever, and it was downhill from there. Wow. However, I did take a distant second in the competition, so I did okay.
Who else was there? Grant McFadden?
Ed Niles, Stuart Schumann, my buddy Nassim Musashi, Grant's son Baron McFadden. I don't know, is that 8? Doesn't sound like it's 8 yet. Me? I might be missing somebody.
It's enough for influenza.
Yeah.
You got 8 segments.
Yeah.
So that's great. All the pox virologists come and play golf.
A good time was had by
Very
all.
Good. It's a good group.
A really good group, that can actually get together and play golf and have a good time.
Mm-hmm. It's rare in virology, isn't it?
Uh-huh.
All right. Today we have 2 additional guests. We have a special guest from Camden, New Jersey, just across the river from Philadelphia, I guess, Dr. Alfred Sacchetti. Welcome, Al.
It is an honor to hang out with such an esteemed scientist.
Well, it's an honor to have an esteemed physician with us, someone who deals with viruses in a practical way.
That's right.
I'm looking around me here for an esteemed scientist.
I don't have one around here. So.
Steamed?
I've seen a lot of steamed scientists, but never esteemed.
Yeah, we have a lot of steam here. You are an emergency room physician, is that correct?
Correct. I'm the chief of emergency services at Our Lady of Lourdes Medical Center in Camden, New Jersey, which is just across the river. And I'm also an assistant clinical professor of emergency medicine at Thomas Jefferson University, which is in Philadelphia itself. So we're one of the teaching sites for their training program.
Do you actually reside in Pennsylvania or New Jersey?
No, I make my home in New Jersey, literally just outside of Camden, a place called Voorhees.
Well, you and I are co-inhabitants of the same state.
Yep.
Both live in New Jersey.
And so do I.
I forgot about you, Dickson.
That's okay, Vince. I'll be happy to remind you.
This is a New Jersey-centric podcast today. How about that? Well, before we get on to Al, we do have an in-studio guest, and her name is Destiny from California. Welcome, Destiny.
Hi, thank you for having me.
You are a TWiV fan, right?
That is correct.
And you're visiting New York. I think you went to interview with Rich Condit down at University of Florida, right?
I did back in March.
And found another TWiV fan?
I did.
Yeah. And now you're going to graduate school. Where are you going?
I decided to go to UC Davis.
Right.
That'll be great. That'll be good fun.
So you're
going to major in plant viruses?
Probably not sure yet, but you are going to work on... You want to be a virologist, right?
I do want to be a virologist.
And that's because of TWiV, right?
It is because of TWiV. I always been interested in the biomedical field, and looking for podcasts one day, I came across This Week in Virology and fell in love from the beginning.
There you
Fantastic.
Go. All right.
Excellent.
Welcome to the TWiV studio, and you're welcome to ask questions and comment anytime.
Well, thank you.
Yeah, we don't often have a date with Destiny.
Alan.
What's the time to pun is 7
right.
minutes, I
So
think.
that's a
I've
good
been
sign.
sitting on that one since I saw the show notes.
Tell me
so
she hasn't heard that before, Alan.
Yeah, it's,
You know-
I know. I just had to get that out.
If
Sorry.
you were the sole guest, Destiny, we could have used that as an episode title. But we have to use something to do with emergency rooms. But it's a good one.
I'd still go with Destiny. I don't think you're going to push that for another decade, guys.
What about a Destiny with the emergency room? Something along those lines.
Ooh, that could work. I'll have Alan work on it, right?
What was the suggestion?
Go ahead. Tell him again, Destiny.
Something like an emergency room Destiny.
Ah,
Combining Destiny and emergency rooms. We'll let Alan work on it. He's got an hour and 20
Destiny
minutes.
in the emergency room. I'm not sure we want that one. Okay.
You don't want to go to the
All right.
emergency room. So, Al, I want to get a general idea of what generation you are. Are you sort of my age or younger?
I am your age. I was born in 1953, so I'm 57. So I'm just
same
about
year.
your age.
Same year as
Yeah.
I. What month?
October.
All right.
So,
You're a bit younger.
yeah, just a tad.
All right. Got it. So where'd you get your MD?
Let's see. I went to LaSalle College way back in the 70s, and then I went to the Medical College of Pennsylvania to get my MD degree, and then stayed on there for my postgraduate training in emergency medicine, which was finished in, I guess, 1982. And back then, it was kind of interesting. Not many people went into emergency medicine. There was only about 5 training programs in the country.
Right.
So it was kind of just beginning to be recognized as an area of specialty.
And through medical school, you knew that you wanted to work in emergency medicine, or did you have other interests?
Actually, in medical school, I couldn't get focused on one thing. I have a bit of a bad case of ADD, which makes emergency medicine just about perfect. So, it was just about, by the time I was getting towards the end of it, it was, you know what, I learned this, I don't want to give that up. I learned some peds, I don't want to give that up. I learned some surgery, I don't want to give that up. And emergency medicine just fit perfectly.
Right.
So it was actually a real nice fit. So, and it's been that way for 30 years now, 30 some years.
That's terrific.
We had a ER physician on TWiV, right, Dickson?
That's right.
Joshua Stillman,
Correct.
who's here at Columbia, right?
Yeah, he used to assist us in our teaching.
Right. So did you ever want to be a scientist, Al?
Yeah, actually, I was a chemist in my undergraduate years, and it was a real tough decision coming into whether to go for a PhD or an MD back in the day. And a little bit of it was I was the first generation. I was part of that first generation of immigrants that kind of went to college. My grandparents came over on the boat, literally. My parents' generation most kind of made it through high school or vocational school, and then my generation came along and we didn't know much about anything. So I was getting towards the end of college, and my mom and dad were more job oriented. Said, well, "What are you going to do? You got to get a job." And it was like, "Oh, I don't know." They go, "Well, can you be a doctor?" It's like, "Yeah, I guess I could." So I wound up going down that path, but I've always had very much of an interest in the sciences. And even after getting my medical degree and in through the residency training, kept my hand in research. And we've, at our shop, we still have a fairly active research program. We've put out, I guess, about over 100 journal articles now in the last 30 years or so.
Wow.
So yeah, we it's a little bit different than and it's hard to call it research what we do, because what you guys do is scientific research. The medical science allows you to get a little bit kind of squishy in what you call research. So I can see an interesting case and write it up and get a journal publication out of it, and somebody will call that research.
That's really a case report, right?
Correct.
Okay.
Correct. So we can do a fair amount of that, but we do a lot of our research is centers on best practices modeling. We do some computer modeling, and we do a fair amount of where we'll do some database work, where we'll actually set up some registries and enter the collections of patients into them, and then go back and look at the registries to see which therapies affected outcome the best. So it's not exactly the type of research that you folks do, because it's very difficult in the type of department I have to be able to do, prospective studies where I can set up and say, okay, every other flu patient is going to get treated with this drug.
Yeah, sure.
And you really kind of need the university infrastructure to do that. So at our shop, we're a little bit more of a look back and see what we did and see what worked and didn't work type of a place. Does
the ER, though, typically lend itself to clinical trials of that sort? Not really, right?
You can do it at the university hospitals, because what they do is they'll get some undergraduate students or medical students who can collect the data. So if you have, for example, if you're doing a study on an antiviral drug, what you would do is, the enrollment forms are, dozens of pages long for those patients. So what you would do is you'd have an undergraduate student hanging around the department, and they would say, okay, this guy looks like he qualifies. They would go in and, check off all the data and collect all the data from that individual. And then you would just randomize them to either get the placebo or the study drug, and then track them long term. But it's a big infrastructure to do that type of work, and a lot of it is funded by the pharmaceuticals, which is difficult. The one nice thing about what we do and the type of research we do is we don't need any grants to do what we do. And we can literally, you look at the amount of sweat that goes into an NIH grant is just amazing.
Yes, tell us about it.
Yeah, for real, I have such a huge amount of respect for anybody who's been able to do that, because I look at that and I go, oh my goodness, that's an art unto itself. Whereas I can literally sit down and with one of our databases or on one of our other studies, and we can just go through the data. Now, obviously, we need an IRB approval for what we're looking at and what we're combing the data for. But we can do that with absolutely no external funding. So it's in that respect we can do things like that. But to do some of the really hardcore emergency medicine research that's out there, you're either getting NIH funding or you're working with someone in industry somewhere.
So in your original email, you mentioned that your department treats 57,000 patients a year. Is that busy? Is it somewhat busy? Is it less than some other places? It's
let's put it this way. By New York standards, it would be a modest-sized emergency department. The Columbia, I'm sure, treats it over 100,000 in their emergency department. For a community emergency department, which is technically what we are a academic community emergency department, which means we do some resident training and teaching. For us, we're moderate to large size.
Okay.
Actually, does Columbia still have an ER? They didn't have a very big ER when I was there.
Oh, they do. No, Josh Stillman is still in that department, so I know it's still there.
Yeah, in fact, one of our young attending docs, she just came on board 2 years ago, trained there.
Yep.
In Columbia. Yep.
57,000 patients a year translates to 156 patients a day. That sounds busy to me.
Yeah, it does, doesn't it?
It can get a little bit on the hectic side.
So, Al, are you in there in the trenches, or are you sitting in office all day?
No, but one of the nice things about my field and my job is I can do both really easily. I said majority of my hours are still spent putting the white coat on and going around the emergency department and seeing patients primarily. The nice thing is, if you look at Columbia, one of the problems with the place of the university problems like Columbia is as the attending, which is the guy who's finished all their training, you're going to be supervising mostly junior residents and medical students. Whereas at our place, we have residents from the Thomas Jefferson program, and they're there for about 8 hours a day. So we spend some time supervising them, but the vast majority of our time is direct patient care, the ones going into the room and seeing the patients. So it's actually very, very nice. And then I spend I was trying to get the percentages right for you guys because I knew this question might come up. I do probably about 25 to 30 hours a week direct patient care, and then another 20 hours a week on administrative stuff, and then about another 10 to 20 hours on research teaching type of stuff.
That adds up to a lot of hours. In case guys weren't doing the math.
What's the math? What's the math on that?
It's still about 80 hours a week. But you know what? It's a lot of it. It's more hobby than work. You know, if I'm at home, you know, meandering through one of our databases or something, that's more of a hobby than it is work. So
it's been my observation though that when I envy in a sense the docs that I interact with, because really part of the job is to continue in patient care for your whole career. You really want the experienced guys doing the patient care. Whereas the sort of the common fate of people doing bench science is to wind up in their office and die a premature death there.
You are absolutely right, because I remember even in my undergraduate years, you know, I was always poking around with whatever, you know, the professors were doing. You just kind of, LaSalle was a small college, and it was easy to get your nose into everybody's business there. And these guys, you know, they love to get into the lab, and you know, we were, you know, as a chemistry department, so they just love to get in there and set up the reflex reactions and everything else and see what came out. And they would lament that they just never got to do that as much as they wanted to.
Right.
So, Al, you had said about 10% of that 57,000 are related to viruses. So why don't we go through that list of viruses that you sent me?
Absolutely. And that 10%, I'm going to tell you, is a real conservative number. If you think about it, because you know, a lot of what we see is virus related. And what I basically did is I just, you know, went through a year's worth of patients and just tagged some of the diagnoses as virus related, and either tagged them as directly virus related, which would be something where the virus was causing their symptoms, or indirectly virus related, which is actually the virus wasn't causing their symptoms, but their ultimate disease had a viral origin. Mm-hmm. So, you know, if you came in and you had herpes zoster, which is you had a this vesicular, extremely painful rash that ran around one of your dermatomes, and it's typically in the chest area. So it would run from your back along your right side of your chest, would be this really nasty looking rash that's very, very painful. Right. That would be a direct viral, you know, presentation. But
shingles for the commoners.
And for that, you don't need a lab diagnosis, right? You just look at it and say, this is shingles.
Absolutely. Okay. That's the one where the security guard says, where do you want me to put the guy with the shingles?
I hope you didn't say put him on the roof.
Yeah, really. Don't put him near me. The indirect would be the same guy comes back 6 months later and he says, you know, my rash has been going for 6 months, but I just got this ungodly pain. It's this burning I can't get rid of. In which case he's got, you know, a post-herpetic neuralgia. The virus is long gone, but the nerve has been disrupted in such a way that he's continuing to feel pain there. So, you know, that would be, you know, I would classify that as an indirect viral presentation. And some of them are actually more interesting than others. If you look, it was kind of interesting because most of the people in the department know I've been listening to TWiV for a while, so they did their best to recruit patients to support everybody on TWiV. So we've got, for Rich, we got, I think the exact number here for you, Rich, we had a bunch of cases. We had 5 cases of molluscum contagiosum last year.
So were those kids?
Yes, all 5 of them were children. Yep.
Okay.
And I know it's a pox virus, and I know what it looks like. These children usually come in, they've got a rash, and it's usually not a very big rash. It's usually on one of the extremities, and they're these almost pearl-like little lesions on their skin with a little dent in the middle of it. They call them umbilicated. Yep, is the way they're described.
Right.
And I took a lot. I saw them. I said, "Geez, you know." And if you nick the skin over them, the pearl actually pops out. I was tempted to stick one in an envelope and send it to you someday.
So these are not vesicular, right? They're like nodular. Is that right?
Absolutely, yeah. And it doesn't fit with what I always think of as a pox virus. I always think of, the pictures that you see of the people with the smallpox or the monkeypox or something. And then it's funny because the parents, who bring these kids in, they're always convinced that it's something horrible. And you go, no, it's just a virus. And they go, okay, what are you going to treat it with? And it's like,
nothing.
Yeah, a little bit of tincture at a time. Yep.
Yeah.
How do you diagnose this molluscum?
You just look at it.
That's it. No culture or anything. No.
Yeah, I think the security guard can do that one too.
Okay.
Except he'd have to be an old security guard because they have to be around for a while.
What does the kid feel when he has this?
Nothing. They're actually pretty much asymptomatic. They don't have no fevers or anything along those lines.
Any scarring afterwards?
No, actually not. Unless you get a wacko ER doc who decides to start cutting them and popping them out.
Oh, Jesus, right.
But for the most part, they're pretty benign. They go away on their own.
Right.
And it's one of those viral diseases that's just so clear. You could look at it and go, I know what this virus is. This is molluscum contagiosum. I got a name I can attach to it. So many of what we see of the viruses we see, all we can say is it's a virus. I can't tell you what it is, but it's a virus.
So those lesions, if you cut them open and look at them, you'll see pox viruses there, and they're unmistakable. We don't know a whole lot about this virus. The genome is sequenced, and so that supports a lot. You can tell a lot of stuff about the virus from that, but it can't be grown in culture. So that limits our information on it.
How do you acquire these infections? Kid to kid?
I think so.
Yeah, we don't see them in clusters, which is interesting. They're scattered throughout the course of the year, and they don't seem to be seasonal. There are other viruses, and we could talk about that we clearly get in clusters, but this isn't one of them. So I'm not sure. And you usually would expect, a skin to skin contact with all the kids, running around each other in daycare and whatnot, that we'd see more of it, but we just don't.
I wouldn't be at all surprised if this was a situation where there are a lot of subclinical infections, and some kids show up with it and some don't. So there's probably, some support for the growth of the virus. I'm making this up, right? I don't know this, and we don't know much about the virus.
You may be dead on, Rich. Because I'd be willing to bet you're probably right. There's kids running around with molluscum that nobody even notices. Yeah.
Otherwise, that small a caseload wouldn't be enough in the population to really support transmission of the virus over a period of time. So my guess is there's some really quiet stuff going on, and we don't know.
Also, you're only seeing the ones who come to medical attention.
Right.
And there may be, given that this isn't causing fevers, doesn't seem to be causing the kid any distress. I mean, a lot of parents would look at it and say, it'll go away.
Or they bring him to the pediatrician instead of go to the ER.
You see this in age patients too, is that right? AIDS patients?
Have not seen that much of it in them, to be honest with you. Usually when the AIDS patients come to us, they got
other stuff.
Yeah, they have other stuff, and they know that we really aren't that great at dermatology, so they don't come to us for that.
Okay. So the molluscum contagiosum kids, you just basically say, that's what it is, can't do anything, but it'll resolve itself, go home, right? Yep.
Exactly, which unfortunately is pretty much our management of most of the viruses these days. It's interesting because the number one viral illness that comes up is just viral syndrome, not otherwise specified. Now, I will tell you, we cheat a little bit, and we'll put things like influenza into there because it's with all the I guess the attention that got generated by the H1N1, telling people they had influenza, people thought it was a death sentence. So we just tell them, looks like you got a bad virus there.
So what is this virus syndrome? Fever and some other symptoms?
Bingo. It's basically some symptoms that they may be upper respiratory, runny nose, cough, those types of symptoms. You may a little bit of a fever, but nothing that we could find to describe it as any other disease. So you would, if you came in and I saw a clear-cut pneumonia on you and you had some, kind of rusty-colored sputum, I could say, I know there's a bacteria that goes along with that. But when you have scant sputum production, you have a bit of a cough, bit of a fever, may or may not have a runny nose, you would be pretty much fit in the category of you got some type of an infection. I don't think it's bacterial because you're not fitting into any of the bacterial areas. You don't look like any of the classic symptoms of a particular viral illness. Your virus syndrome, and people will accept that. What happened with the influenza was that it became people just got very excited about it, and they all wanted to be treated for it. And the reality of it is, if you show up with influenza, whether it's H3N2, H1N1, whichever one you show up with, unless you are there the minute you got your first symptoms, none of the treatments, the Tamiflu or any of those, don't really work. They'll shorten your length of your disease by about a day, maybe a half a day. So we really didn't want to be giving a lot of Tamiflu out, and mainly because people were showing up on their second or third day, and by then they'd already declared themselves that they didn't have a severe case and they were going to do just fine. So you really didn't want to get a lot of Tamiflu out into the community that you didn't have to. So we basically told people they had a viral syndrome.
So you didn't have numbers here for flu. Is that because you don't diagnose it, or?
Well, we do diagnose it. I went back and looked at that because in 2009, I think we actually diagnosed probably about 400 or 500 cases of it. Actually had a diagnosis of influenza, and that was because at the time the departments of health wanted us doing all the nasal washings and doing all the antigen tests for them, looking for influenza because they wanted to track it. This year we had 17 cases, and I will tell you that's not because we weren't putting the diagnosis down. We saw almost no influenza this year at all.
And what's a typical year, non-pandemic typical year besides this year? Is it 17, 20 a year or?
Not typical year. We probably go about 1,000 cases. A year. It depends on the year too. Remember, some years you get a very mild influenza season, and some years you'll get a really severe season. So it'd probably be around 800, maybe 1,000 on a bad year. So last year would have been, or the H1N1 first year for the H1N1 would have been a bad year. And it's tough to guess too, Vince, because what happens is, if you remember, H1N1 hit in the spring, went away, came back in the fall, went away, then came back again a little bit towards the end of winter.
And did you see those waves too in your ER?
Oh, absolutely, absolutely. But we can tell you what is evolving in a community pretty much a week or two before anybody else knows what's going on. In the state of New Jersey, actually, one of the emergency medicine groups covers, I think, 5 hospitals or so, and they have their electronic, their billing database. They make that available to the Department of Health, which snoops it, and every now and then we'll get a warning that says, "Gee, there's something something's going on. We're seeing a large number of upper respiratory infections, a large number of gastrointestinal infections." And we already know because we've got it as well. But they search that looking for bioterrorist activities because they figure this is the earliest warning sign they're going to get.
Yeah. So we don't need Google Flu. We just need to monitor the ERs, basically.
Well, actually, you can.
Exactly.
You would be able to do. We can. It's funny because my wife periodically will say, I went to the hair salon and so and so was. Said their child was sick, or so and so was sick with either a gastroenteritis or an upper respiratory type infection, and she'll say to me, "Are you seeing anything?" And I'll be able to say, "Yeah, we had 3 cases today. I saw 3 cases today, which means we probably had 6 to 8." And then I'll be able to say, "Yep, we're seeing a lot of it over the next week," and then it'll taper off. It's interesting the way we can tell that, because what you'll see is the upstroke is very, very steep. But when we start to see the cases, it's not a bell-shaped curve. What you see is a very brisk upstroke, and then it plateaus for a while, depending on the virus. And then the downstroke is much more shallow than the upstroke on it. It's a very classic pattern how we see these viruses come in. This year we saw no flu, and I mean really almost no flu at all. And we have some ideas why. but we saw there was a nasty virus that went, a GI virus that went around that lasted, 24 hours to the minute. The parents were bringing their kids in. It was vomiting. Hour 1 was vomiting. Hour 8, the diarrhea started. Hour 24, kid was perfectly fine, torturing their brother who they gave the disease to. So,
and you didn't diagnose what virus is involved, but it was probably a noro or a rota, right? Well, 24 is probably a noro, right?
Yeah, it might have been a noro, but noro tends to, believe it or not, noro always gets our staff. I don't, and we've got sinks and those foams and everything else all over the place to keep your hands clean. But for whatever reason, no matter how meticulous you are, they always get the norovirus.
Noroviruses are so tough, and it takes so little. Keeping that at bay would be just really hard.
I think you're right. I think you're absolutely right. That is, and I don't think the foams, those alcohol-based cleansers, kill it either. I may be wrong there.
Not 100%. We'll find out from Stephanie in a week or so.
There you go. It's so that always gets it. But the staff didn't get hit with this, but it did go around. And we were at one point, we literally had kids hanging off every corner of the stretcher who had come in with this virus, and it was. And I don't think it was a roto, Vince, because they all had the rotavirus vaccines.
Right, you shouldn't be getting rotavirus.
Okay. Right.
Yeah, I will tell you that's made a huge difference. We used to, every winter, we would have every day 3-4 kids, hanging around with intravenous lines, getting hydrated back up. We haven't had to do that in a year or two now.
So does the New Jersey State Department of Public Health consult with you guys first before they issue an alert to the school systems?
Not us, but not our department specifically, but they are in touch with emergency physicians. Yeah, they've got a lot of emergency physicians who work with them to let them know what's going on and what's flitting through the community.
And do you call them sometimes to be more proactive?
Sometimes what we'll do, we're generally more in touch with poison control when some designer drugs hit the community, as opposed to the infectious diseases. Most of the time, it's more the children's hospitals that'll give them the heads up on the infectious diseases. Although we see as many of the children as they do, they're a little bit their infectious disease folks tend to be a little bit more tied in with the state in that respect.
Sure. Okay. Thanks.
Yeah, this is it's one of the theories behind the whole push for electronic medical records, is that eventually we'll get to a point where all of this can be automated or semi-automated, and you could develop forecasts the way you have a weather forecast. There's a flu front moving in.
Yep.
So that means that all the data would have to be centralized, right?
Mm-hmm. Well, or at least accessible,
right,
from a central point. You wouldn't necessarily have to put it all on the same server. In fact, I certainly hope that wouldn't be the architecture.
It's in the cloud.
Or that Sony would be administering it. But the idea is that the people with the appropriate access would be able to tap into multiple sources.
Yeah, I think they do. To be honest with you, Alan, I think that's exactly what happens. This group submits all their diagnoses on a daily or whatever, some periodic basis, and someone looks through it and they compare it to the previous year. And when they see a spike in a particular diagnosis that's statistically different than the previous year, they send an alert out.
Right. And it's we should probably point out for the audience that these systems are usually anonymized, so they're set up so that the data that are accessible from the central office are not your whole entire medical record, but just a piece of information. A patient of this age presented at this hospital with this diagnosis.
Correct. Yeah, it's scrubbed. The data's all scrubbed, so nobody sees it.
Right. So let's talk about picornas.
Picornoviruses. Those are our favorite viruses.
Yeah, you bet.
Yep. Well, let's put it this way: the number there was 854 upper respiratory infections, which would be translated into rhinitises, rhinosinusitis, those type of infections, pretty much colds. And
they're probably all viral, right?
Almost 100%. And I'd be willing to bet it's probably 90% rhinovirus and maybe some adeno and some other oddball things thrown in there. But we see a lot of if you had to look at it, probably the coronaviruses would be the number one group that we see more than anything else. So we see. Go ahead.
And there's no treatment involved, right?
This is the most frustrating thing about a lot of the viruses is by the time you're symptomatic, your viral load's already going on the downward slope. So by the time you've got, your nose is all stuffed up and your head feels all congested, if we were to look at your viral load, it's probably already on the way down.
Right.
And what you're really experiencing is the body's immune response to the infection.
Yeah.
Yeah.
And that I think is what's very, very frustrating. I remember, Vince, you would know about this. There was a couple of years ago, probably about 10 years ago, one of the drug companies had come to us and they wanted us to do a clinical study for them, which we really are not set up for. But it was interesting. They had a drug called Pleconaril.
Right, Pleconaril. Yep.
Pleconaril, and it was supposed to be able to treat the common cold, I don't think it ever got FDA approved, but I think part of the problem was by the time you started taking it, the virus was already on the downstroke, and really it was the immune response that was the problem.
As you said, by the time you have symptoms, it's already too late to start treating.
Yeah. With
these drugs. The acute infections are so short. Pleconaril in the lab works fine, but you get resistance very readily in patients. So I have a feeling that combined with the efficacy issues just killed it. And until we have some rapid diagnosis, you're not going to be able to use those kinds of drugs.
Yeah, even the Tamiflu, by the time you're symptomatic, it's not going to work that well.
Right.
So we do have. I will tell you the other group of coronaviruses that we see a lot of is the Coxsackie. We see a lot of Coxsackie infections, and those
how do they present? Rashes?
Yeah, Rich had mentioned these really do come in clusters, and when we see one, we know we're going to see a bunch of them that week, and then they go away. Most of them are the oral lesions. They will present with these ulcers. They're kind of a white plaque-like ulcer, usually more towards the back of the throat. The herpes simplex 1 is usually more towards the front. The herpes simplex 1 usually gives you more of the lips and more of the gums. The Coxsackie gives you more the back of the throat, although there's a subset of Coxsackie that gives you just the lips. But when you look at them clinically, when you see the child come in, the child will look miserable. They're usually somewhere between 8 months and 2 years of age. And they'll look miserable because they'll have a fever and they haven't been drinking, so they're a little bit dry and they're fairly cranky. And you look at the lesions and they're these flat ulcers with a white base to them. We usually don't see much in the way of true vesicles with them, and they're very, very painful. And it's tough to get the children to actually drink, and that's the biggest problem with them. And when we see one, we'll see a cluster of them, and some of them will present with the full-blown spectrum, where they'll have it on their hands and on their feet. So that's the classic hand, foot, and mouth disease. So they'll have little. It's never as dense a cluster of lesions on the hands and feet as it is in the mouth, but it certainly you can see them there. And the other place that people don't look is they'll have it around their anus as well, because they swallow the virus, it makes it through the GI tract, and then there's a mucosal surface down around their bottom, and they'll have it there as well. You can see it.
So none of these are laboratory diagnosed again, right?
No, it's a pretty classic picture when you see the oral lesions for them. So you're really not going to mistake it for much. And you can argue, well, geez, don't you want to know the difference between herpes simplex 1 and Coxsackievirus? And the answer is not really, because whatever it's not, they're going to get that one in 6 months. So it's a rite of passage for these children.
And there's nothing you can do about it, right? So. No, you don't want to. If you had antivirals for all of them, and you could diagnose in, say, a half hour from a blood specimen, then obviously you would do it, right? Correct.
But there is no management for them. The scary thing about the Coxsackie is, we don't see it, but once every 3-4 years, is we'll see the child that comes back with the myocarditis from it, and that's the inflammation of the heart. And those kids have a real rough go of it. And what's interesting is when you read, at least my read of the literature, is the virus doesn't grow in the myocytes, in the actual muscles of the heart. It's just, again, the inflammatory response that produces the problem.
There is some growth, but the main damage is caused by probably T-cell mediated killing of myocytes. Yeah. So, therapies to intervene with that are probably worthwhile, but then you need a diagnosis, a blood test of some sort, which we don't have yet.
Right, and again, that's you've got this virus that's generally a pretty benign virus. It's an uncomfortable virus, but it's a benign virus. But the sequelae of it, it's the body's overreaction to it, and then it I guess there's a cross antigen that's on both the Coxsackievirus and the cell surface of the heart that leads to all the problems.
Yeah. So those kids who have heart infections at that age, what happens? Do they have a chronic infection their entire life and then require a heart transplant? Is that the outcome?
No, I think they clear the infection. When we see them, we don't usually see the myocarditis. We see the myocardiopathy afterwards. Okay. So they'll have the inflammation, which you may or may not pick up, and unfortunately, the standard of care is to miss it. I mean, most of the time, these kids come in and you'll look them over, and they have a little bit of wheezing, and you don't see much of anything. The only dead giveaway on them, and I had learned that a buddy of mine had told me this a while ago, is when you listen to their heart. Normally, you listen to a child's heart, the sounds are very crisp because they're small. You can hear the heart's right up against the chest wall. You can hear it real clearly. And their hearts are very forceful when they beat, and they slam the valves closed, and that's what you hear is these valves closing. When they get the myocarditis, the heart muscle is very weakened, and what happens is the valves don't slam shut; they just kind of close shut slowly. And what you hear is a muffled heart sound, and that's really the only giveaway that something's amiss. We usually see them when they come in even later with heart failure. So you'll see a child who's not eating and drinking real well, their liver's swollen, they're a little bit edematous, and by then you look at their heart and it's this giant sac on the chest X-ray, and that kid's now got a cardiomyopathy, and they frequently will go on to need transplants.
So for those, you need an early pickup of the presence of the virus so that you can do something, right?
Right. Those you would hopefully be able to do something, and I think, like you said, they would probably try an antiviral. I'm not sure what you would use for Coxsackie. I don't know if Leconaril, they would try it. But the big thing there is to hit them real hard with the any of the anti-inflammatory things, try and downregulate your immune system.
Yeah.
Vincent, are there a bunch of different serotypes that do this?
There are several of Coxsackies that will do it, yeah, more than one.
Okay.
And so there really aren't any antivirals except for the Leconaril, which may not work for all of them. But I think if we had an early diagnosis method, then the companies would make antivirals,
Well,
so,
the two ways to attack this would be to either go after the virus and treat every kid who comes in with Coxsackie by diagnosing it quickly and giving an antiviral, which there's a fair amount of rationale for doing that. If it's, these kids are obviously uncomfortable. Or you could just aim for the heart cases and try and develop better anti-inflammatories, which is probably a tougher nut to crack.
Yeah.
Vaccine. You need a vaccine.
Yeah,
that'd be nice too.
There's multiple serotypes. Yeah, these infections are quite prevalent. I mean, all the enteros, probably millions a year in the U.S. alone. Most asymptomatic. So it's not that it's uncommon, but some vaccines would probably be useful.
So, Vince, when was it first discovered in Coxsackie?
What?
The virus. I mean, it's named after the city in New York. So
1947 was the first isolate from Coxsackie, right. New York. Yeah, it was thought to be polio. They thought they had an outbreak of polio up there, and they isolated these viruses, which can also cause paralysis. So they can do heart infections, various muscles, paralysis, respiratory infections, and there are quite a few different serotypes. So vaccines.
But it's really a pandemic. You say it's really found everywhere.
I know in the U.S. there are millions of cases of enterovirus infections every year.
Sure.
And we don't actively diagnose extensively, and I think globally they're present extensively as well. But the research goes to the more compelling problems, and clearly there's a need here. I suspect that one day we'll get to it.
Yeah, if you're attacking it at the late stage with an anti-inflammatory, that's something that a lot of people are working on because it's so compelling for so many different diseases.
Sure. I mean, many years ago, Lindsay Witten showed that there's a mouse model for myocarditis caused by Coxsackievirus. As you infect the mice, it replicates in their heart and it gets destroyed. You can take away the cytotoxic T cell protein that is responsible for cell lysis. If you knock out the gene encoding that in mice, you now infect those animals with Coxsackie, you have significantly less heart pathology, which suggests very strongly that that's it. The immune response is causing the heart cell killing. So, you have to be able to diagnose it and say the virus is here. And then if you had a drug that would prevent that killing, you could try it. That's one route anyway.
It would make perfect sense, Vince, because I think when we look back at some of, and it's not just Coxsackie, but a lot of the viruses, it's the aftermath that where all the damage is done.
Post-viral syndrome,
Right.
So, Al, I was very interested to see the viruses that you did not find.
You're leading me on to my soapbox. I am such a huge fan of the work that the virologists have done and the vaccines you guys have produced over the years. It is amazing. We did not see in 2010 a single case of measles, mumps, rubella, polio, yellow fever, varicella, hepatitis B, variola, and or rabies.
What about West Nile?
Actually, we did not see a case that. Well, let's put it this way: we did not diagnose a case. I can't tell you we didn't see a case. We did not diagnose a case of West Nile.
Right. Have you ever seen it in kids?
We've not seen any, but we see the occasional viral meningitis, but those are usually the echoviruses. They're not usually the. They may have been West Niles, but when we do if I do a spinal tap on a patient and it comes back looking like meningitis, I will gram stain it. If I don't see bacteria, and depending on what the blood cell count looks like, it most likely is viral. I'll never know what the virus is because that patient will get admitted, and they send out the serum. We always draw an extra tube. They're the digitubes, so that what they do is the infectious disease guys come down and say, "Did you send it out for this titer?" And we go, "No, but here's a tube for it." So they have those tubes, and they don't come back for weeks. So we, like I said, we don't have that much of our attention span's too short to follow somebody up after a week.
Okay.
So we never know what they had, but those will be our viral meningitises. So we may have seen some cases of West Nile, but if we did, the way New Jersey's set up, if you diagnose viral meningitis, a sample goes to the state to test for West Nile. And that always makes the newspaper in this neck of the woods. So I don't think we had that many cases.
Okay.
So what's this soapbox you were talking about?
This is I am a huge fan of vaccines. I mean, you look at the number of things. When I started medical school, one of the first cases I remember very clear. I was a junior medical student, running around the emergency department, gaping at all kinds of interesting things. And my buddy comes running up to me and he goes, "Hey, come here. Let me show you something." So we go into this room and there's this I remember very clearly, this 7-year-old kid in there with this family with a fever. And he says, "Open your mouth." The kid opens his mouth and he's got these little white spots on the inside.
All right. I know what those are. Even I know what those are.
Go ahead.
Conflict spots, right?
Got it. So this kid had conflict spots. He had measles. And I don't know the virology of the conflict. Do you remember the virology of it?
No, it's got to be some. It's very, as you're pointing out, pathognomonic for measles. Any other way, it must be some sort of peculiar immune response or a combination of a cytopathology and immune response.
Yeah, it's like it's fusion of cells by viral replication and then CTL mediated, immunopathology.
The very first case I ever saw in the emergency department was this case of measles. Well, last year I get this call from one of our younger docs, and she says, "I'm at my pediatrician's office, and I'm here with my 3-year-old, and he's had all his shots, and he's got this rash." And I said, "Well, listen, I'm the world's worst at rashes. And besides, you're there with the pediatrician. She's got to know better. She goes, no, you don't understand. We think it might be atypical measles, and neither the pediatrician or I have ever seen a case of it. But you're old enough to know what it looks like. And I thought, well, you know what? This is really telling that here you've got two physicians who've never seen this disease before, because the virologists were so good at developing a vaccine and eliminating this disease. I mean, that's an incredible accomplishment, because if you go on the World Health Organization's website, the number 5 cause of death in people under 5 years of age is measles.
Correct.
So the whole concept that we've got that the virologists have been so good at eliminating these diseases is just astounding to me, and that yet we have a portion of society now that doesn't think this is a good thing to vaccinate their children.
Yep.
Well,
for precisely the same reason. They've never seen measles either.
Right.
That's right.
It's partly true. I remember it was one of the pioneer radio announcers. They were interviewing him towards the end of his career, and they said, what was the biggest thing you've seen? He said, the biggest change. This was back about 1990. He said, is in my generation. He was probably about 80 or something. Then he said, everybody lost a sibling or two as they were growing up. You lost them to a disease, trauma, or whatever, and you don't see that anymore. So people don't appreciate, all the advances that have made your child growing up today as safe as it is. And I think Alan touched on it. That's true. You don't see somebody whose kid died from measles, or someone who's deaf from rubella, or any of those types of things. So you don't realize how frightening it was when you saw your child. You woke up one morning and you saw your child, covered with this rash, and how you worried over the next 3 or 4 days because there was nothing anybody was going to do for them.
You had mentioned some Hep C, but we've not seen any Hep C infections so far. So do you see those in the ER? And you said you're more scared about those than HIV. Why is that?
Oh yeah, we see a lot of Hep C. We're a liver transplant center, so we see a lot of these patients. I sent you a link to a video. I don't know if you were able to it worked or not. It's basically a patient with massive ascites with hepatitis C that we did what's called a paracentesis. Basically take the most pregnant person you have ever seen in your life and double it. And that's what these people look like. And they're Dickson should know, because there's a lot of parasites that'll give you massive ascites. They get in the liver and they clog it up.
Yep.
But so we see them, we drain them, we see the pre and post transplant. Here's the horrible thing about hepatitis C, and this is what is most frightening. And I listen to you guys every week. And you guys all you're looking for problems to solve. Nothing makes you happier than for somebody to pose a question to you and you guys try and solve it. If you get hepatitis C and you wind up with hepatic failure, so now you can't detoxify all the blood coming into the portal system from the gut, and your ammonia level rises and stuff, your ability to not just solve those challenging problems, which you guys really delight in, but you can't even solve the problem of deciding when you have to go to the bathroom, you begin to just deteriorate. You can't take care of yourself. You're a burden on those around you. They're your loved ones, and they're going to take care of you. But nobody wants to be in that situation. You're no longer contributing to anything, and it's just an awful disease. In that respect, to see people, come in with that, and we obviously see them all the time. You can get their ammonia levels down. You can do various things to them, but it's an awful disease. And then you begin to develop varices. It's basically swollen veins in the esophagus, and you bleed from that, and it's just a horrible chronic disease. And when you talk to these people, some of them are drug addicts, and that's where they got it. But a lot of them got it. They're a friend of who they had relations with 10 years ago, 20 years ago, had the virus. They picked it up from them. It just lies smoldering for decades, and then just all of a sudden your liver's gone.
Wow.
But now, of course, we have a number of good drugs coming down, some of them imminent. So you're going to see less and less of this, presumably, right?
Absolutely. I mean, this is one thing we, for us, I mean, not only is it a bad disease, but what scares us is, when you get your needle sticks, if you get stuck with a dirty needle in the emergency department, that's, the emergency department takes care of everybody in the hospital who gets a needle stick, including ourselves. And I got stuck a couple months ago, and it's a fairly frightening thing when you look at it now. If you get stuck from somebody and you know who the patient was, so it was a patient comes in and you're putting their intravenous line into your drawing bloods, or for whatever reason they twitch or jump and you get stuck, it's not too bad. We have a protocol. We draw blood from them. We know what viruses they don't or don't have, and they draw blood from the employee or the hospital personnel, and we know what your viral titers look like. And then you can determine your management. But if you get the other, when I got stuck with a needle from the needle box. It was, improperly disposed of, and I was trying to get it into the way it should have been disposed. Something slipped and the thing sprung back and stuck me in the hand. So I didn't know who it came from. So it's an unknown source. And so we have a protocol that you go through for that, and they draw all my blood. I get my baseline stuff, and then they will offer you what's called a post-exposure prophylaxis, where it's one of the HIV regimens that they will offer you as to whether you want to go on this or not until they follow you long term for this. And most people don't. The even with a dirty needle that's HIV positive, your conversion rate to HIV is 0.3%. So that's pretty low, and these drugs make you pretty sick. So most of us don't take it. All of us have hepatitis B vaccines, so we're all immunized against hepatitis B. So the worrisome one is hepatitis C, and that's about a 1.8 conversion rate. So it's a 1.8% of the people stuck with a needle will seroconvert. So that means that pretty much 1 out of every 100, 1 out of every 50 people is going to seroconvert and stuck. And we actually had one of our residents get stuck about 3 years ago who did seroconvert to hepatitis C. And the interesting thing is, even though there's therapy for hepatitis C, it doesn't prevent you from seroconverting. So if you get stuck with a needle and they immediately put you on the interferon and the ribavirin, it doesn't impact whether or not you convert or not. Mm-hmm. So it's a little bit scary there, because then once you convert, now you're looking at all this pathology and the way these people end up. It's particularly frightening. You guys had some guests on there, some hepatitis C experts, and there is a percentage of people who, if you treat them for a year, will become seronegative. And this resident did. We treated him for a year, and he ultimately turned negative. Wow. But what they do is, in 2 weeks after my needle stick, they draw blood and they do a PCR on it, looking for hepatitis C. And if they don't find any, then in 6 weeks, they come back, they do it again, PCR, antibodies, antibody titers, and they start checking you for HIV. So you're checked at that point for HIV, and then I think my next check is at 6 months, and then at a year, they do them all again.
So you said you prescribe Valtrex, but not Tamiflu. The Valtrex, I presume, is for herpes infections?
Yes. Yep. The reason is the herpes infections last long enough for it to make a difference. Yeah. Sure. If you get a herpes zoster, the shingles, or if you've got primary herpes simplex 1 or 2, this is a disease that lasts long enough that if you start them on an antiviral, either acyclovir or Valtrex, any of those types of drugs, it'll work. And the other thing is, people who have chronic herpes simplex infections of the mouth will tell you, or genital herpes, as soon as they get the tingling and the data's out there is very good, start them on the antiviral, then it'll abort the infection. But the Tamiflu, like we said, it'll shorten it by maybe 1 day. And the gut feeling now is, I don't want this drug out there circulating, generating resistance. Yeah, sure. I want to save it for the pregnant patient with H1N1 or the child under 2 with H1N1 who's now got a bad viral pneumonia. And that's the person you want to use it on.
So aside from Tamiflu, Valtrex, what other common antivirals do you prescribe in the ER?
The only really one you'll see us prescribe is the anti-HIV ones.
Okay.
They're about the more common.
Right.
Now, we will use eye drops. We'll use the Valtrex eye drops for people with herpes simplex keratitis, where you get the infections of the cornea.
Right.
You'll see us use them, but otherwise, it's more symptomatic treatment than anything else.
Yeah.
And that's for the primary viral infections. You start to look at all the secondary viral infections. Personally, I consider diabetes, juvenile diabetes, to be a viral infection. If you look at the epidemiology of it, it just so looks like a virus. The new cases occur in clusters, and it's in a school age population. And when you pin them down, if you really get a great history, you can always get a history of about 6 months prior some type of a viral infection.
It's interesting because the virologists are still not sure.
Right.
Right. There's still a lot of debate.
Yeah, the it just epidemiologically it looks like it.
Yeah.
It's got that feel to it. But finding the virus that's a whole lot different because there's such a lag time. Because you have to remember, before you start to get symptoms of diabetes, you've got to kill off 80% of your islet cells. So that's months and months and months and months to kill them off. And who can remember what they had or what happened to them 8 months earlier?
Right, and that's a big difference between medicine and science that commonly comes up, is that doctors will often make, obviously you have to make a call based on what you see right in front of you. You can't wait for all the data to come in.
Right.
And I have conversations like this with my wife, who's a physician, and she'll say, well, but this is what causes thus and such. And, well, honey, we're not really sure about that. Well, I'm sure about it.
You lost.
I like your wife.
Exactly.
How about parasites, Al?
Yeah, the only one I found at this time for Dickson was trichomonas. We always see a lot of trichomonas.
Oh yeah, no pinworm.
We usually get 1 or 2 cases of malaria a year that drift in from who knows where. But there's always the kids that come in with the pinworm and whatnot.
Giardia.
I would be willing to bet that we see some Giardia. Usually what we'll do is we empirically treat. If you've been out and hiking and camping and you come back with this god-awful smelling diarrhea, we'll empirically treat you with flagyl on that one. We'll send cultures off on that, but most of the time it's we'll just empirically treat you on that one.
How about Lyme disease? We
see a lot of Lyme disease.
That's what I thought.
Yep. We most common presentation is actually what's called the Bell's palsy, where the one side of your face is paralyzed. Right. We see a lot of. It's interesting. We had 2 of the staff's children were in the fall. Young kids with Bell's palsy, where half of their their face is paralyzed, and it just empirically we just start them on treatment for the Lyme disease, figuring we knew what it was. And the one girl, it was interesting, had come in a week earlier looking very, very much like a viral meningitis. We had done a spinal tap on her, and so we had spinal fluid on her. But then a week later, she came back with the Bell's palsy. We sent the Lyme titer, and the lab had frozen one of the digitube of the spinal fluid. We sent that out, and it was positive for rickettsia.
Right.
So anything else we ought to cover before we move on?
I have a question.
Sure.
It sounds like with a lot of the viruses that you find at the hospital, most of them you can't really do anything about with all the flu-like symptoms ones. So would you recommend that if people have flu-like symptoms that they don't come in, or should they come in just to make sure it's not something else?
That is actually one of the most difficult questions that ever gets posed is when should I go to the emergency room or when should I go to the doctor? And the answer always comes down to it depends on you and how comfortable you are in making clinical diagnosis. We see a lot of parents bring their first child in, but the mom who's got 5 kids, doesn't even call up, and she'll look at the kid and go, oh yeah, you got Fifth's disease, I'm not bringing you in. So she's already making the diagnosis on them. So it depends on how comfortable you are. even though we can't give you an antiviral and take care of the virus, a lot of times we can help with the symptoms. So that there's certain medicines we can give you help you symptomatically, and there is always that subset of people, especially with the flu now, the pregnant people, the very young people who have that really bad reaction to it and wind up with the bad pneumonia. So those people we do need to take care of. So it's a matter of how comfortable you are with the disease yourself. But to be honest, on Destiny, that's probably the toughest question anybody ever asks us.
My daughter has her first child is 3 years old and goes to a home daycare with a very experienced woman, and that woman tells my daughter, when your kid is sick, call me first. I'll tell you whether or not to go to the doctor.
She's right. I agree with her 100%. Our nurses are better at taking care of it than some of our young docs. You'll see this young doc sitting there flipping through the textbook trying to figure out what's going on, and she'll go, "That's roseola. Go see somebody else."
Right.
First child syndrome, right?
Yep.
You don't know what to do, but then you learn.
I got news for you. I learned more raising my 2 kids than I did on the pediatric rotation.
Yeah,
Sure.
You learn a lot about noroviruses with young kids.
Yes, we did.
Yeah. All right, let's go do some emails. You're going to stick with us, right, Al?
Absolutely.
All right. The first one is from Maki, who writes, to the hosts of TWiV. I find the fact that you're called hosts of a virology-centered show endlessly amusing. I never thought about that, but it's right.
Good point.
Yeah.
Having been the weird kid reading Virus Hunters on the playground in elementary school, I've had an intense love for virology and epidemiology for as long as I can remember. Fast forward a decade, and I find myself as a post-bac research tech with my mind drifting toward the possibility of grad school. I've been trying to study on my own in order to focus my brain toward a future of classroom education, but after a demanding day of trying to keep up with advanced degree-level work, it's hard to crack open a textbook and read about single, double-strand DNA, RNA, blah, 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 without my eyes glazing over. Let's not even get into what happens while reading journals. I just discovered your podcast last week, and since it's been a constant source of entertainment, oh yes, I consider it the height of entertainment. During transit and the rote tasks of my day, I want to sincerely thank you for the work you do. I'm eager to listen to the rest of TWiV, TWIM, TWIP, and I know that you're going to be great for the advancement of my education. Heck, you already have been with the first 10 podcasts. Every day that I arrive at work after listening to you, I feel inspired by the possibilities of research, which can be so demoralizing some days, and ready to throw myself into my own current research, despite it not being in my field of choice. Again, thank you so much. Your insight and knowledge are very, very much appreciated, as is your patience with my verbosity if you've made it this far down. And Maki is from the Scripps out in San Diego.
It's a good place.
Nice. Thank you, Maki.
Thank you.
Yep.
Hosts. We're hosts.
We are.
We're all infected. Next one is from John. Dear TWivers, I was just listening to TWiV 122, and this made me think of 2 somewhat related questions. First, you discussed a gene involved in innate immunity inside the cell, TRIM5-alpha, which provides a natural defense against retroviruses, and which has some alleles that have been preserved more or less across species that diverged millions of years ago. You talked about a bunch of possible explanations, but one you didn't discuss involved endogenous retroviruses. I'm curious if that could explain the preservation of some of these alleles in primates. I should point out I'm not a biologist, but a computer scientist, so I may be misunderstanding things here. The way I imagine this working is that there's a population of ERVs hiding out in the genes of different species of primates. Some ERVs reawaken pretty regularly so that in the average individual it's not surprising to have the ERV showing up. In those species, the allele of TRIM5-alpha that protects against them will really be common because it provides a big fitness advantage. But it seems like there should also be some ERVs that reawaken only much more rarely. Perhaps they need a helpful mutation or some really unlikely sequence of events inside the cell before they can come back out. And those would support balancing selection between alleles. If you have some ERV that only comes out once per generation, the value of an allele that resists it is based on how common that allele is in the population. If almost everyone else has it, you hardly need it. Most likely the retrovirus will never spread to you, and you're not at all likely to be the one individual per generation in which the ERV reawakens. The more rare that allele becomes in the population, the higher its fitness value to an individual, and so the more it is selected for. Once per generation epidemics of some nasty retrovirus should keep some level of the resistance allele in the population. The more rare the events that allow the ERV to come back to life and start spreading again, the more rare you'd expect the allele that provides resistance to it to become. But it seems like that should still keep some level of the alleles around. Imagine a once per 20 generations epidemic of something as nasty as HIV sweeping through your population. When that epidemic comes out, the fraction of the population carrying the allele that gives resistance to it will very quickly jump from a small fraction to nearly everyone. My question is, could this account for some of the preservation of these TRIM5 alpha alleles across long-separated species? As long as you have the same or similar ERV reawakening from time to time in two distant lineages of monkeys, it makes sense you'd have the same or similar alleles to provide resistance to that ERV. But this assumes that the ERVs can stick around that long in forms that can replicate under the right circumstances. It seems like the ERVs could stick around by managing to reinsert themselves into the germline when they manage to come out and trigger another epidemic after most of the population had lost its resistance. Is this at all plausible? The more time I spend writing this out, the more assumptions I find I'm making that I don't know enough to confirm. And that's the problem with speculating far outside your area of expertise, I guess. Any thoughts on that before we...
It's an incredibly thoughtful question, regardless of what the answer is. For somebody without a background in virology, I'd say they could be teaching it based on what they could think through the problem with.
Yeah, and I think as a computer scientist, I'm surprised there wasn't any mention of the possibility of modeling this. Because this seems like exactly the sort of thing that somebody who's into biostatistics and those fields would set up a program and run a simulation and see how often the alleles come up and hit it with periodic plagues.
Sounds like he's modeling in his head.
Yes.
Yep.
Yeah, this is a modelable question. It makes some sense, but I don't know about the population selection aspects of it. And we know that in mice there are endogenous retroviruses that eventually the mice evolve to be resistant, but not at the level of these TRIMs. They mutate the receptor, for example. So I don't know that we have any example that this occurs.
Maybe it's a dual function molecule.
Well, that's the thing. Also, if it has another function, then it is constrained, right?
Right.
Yep. And I just read a recent speculation that antibiotics that are produced by actinomycetes and other soil-dwelling microbes may have had other uses besides the ones that we found for our own purposes.
Mm-hmm. Yeah, there's an emerging view in bacteriology that these are communication molecules among bacteria in their natural environments, and it just so happens that at very high doses that we deliver them in, they're deadly to some species.
You mean like quorum sensing molecules?
Something like that, yes.
Something like that. Interesting.
Well, I had sent this question off to Welkin Johnson, and he hasn't answered yet. But he would be the one to get this, and we'll come back to it if he has an interesting answer. His second question involves a book he wants to recommend as a pick of the week. It's a book published in 1949 called Earth Abides by George Stewart, in which a sudden epidemic of some unknown thing nearly wipes out the human race with perhaps one person in 1,000 surviving. Reading this around the same time I listened to your discussion in TWiV 122 made me wonder how likely it is that some epidemic could arise that kills a large fraction of humanity. I know the original population of American Indians was nearly wiped out by disease, though I think it was multiple diseases, measles, mumps, chickenpox, influenza, smallpox, the whole package all at once. How common is it that a single disease kills 99% of the people who get it and also spreads easily? This made me think of HIV because it's always seemed to me that if HIV had been spread by casual contact, it would have killed off most of humanity. The several-year incubation period before it becomes lethal would have kept us from noticing it. Who noticed one more flu bug going through the gay community in San Francisco till people started dying from it years later? I know there's some fraction of people that don't get it. They have a variant co-receptor that keeps the virus from entering, and others that catch the virus but seem to control it indefinitely. It's the MHC-based controllers. Is there a good figure for what fraction of people total don't die of HIV? How common is it historically to see one disease nearly wipe out a whole population? Thanks for your podcast and answering my amateur questions.
Not so amateur.
No, not amateur at all.
I don't know of anything that wipes out all of 99% of Earth's population, right?
There's nothing. The one I can think of is plague when it swept through Europe the first time, but I mean that was about a third of the population. That's right, about 1/3.
Well, the introduction of smallpox into Mexico and South America, yes. I've heard a lot of different numbers on that, but I've heard numbers as high as 90% of the Aztecs got trashed by smallpox.
But it's very difficult to dissect that out from all the other things that were going on at the same time. I mean, a lot of them died of lead poisoning from all the bullets being shot at them.
Right.
So it's
When you take smaller groups of people, though, it's easy to understand how it might actually happen. The Huron Indians don't exist any longer, and I gather that historically that was because of smallpox.
Right. Now, I guess an easier way to ask this question is there a virus that can wipe out 99% of the population of the host that it infects?
Well, rabies can do that, right?
Rabies is pretty good.
Rabies is
but
pretty
that
good.
doesn't go from person to person.
But it doesn't travel through.
Right.
No.
It won't reach 99% of the population.
Right.
No, I'm not talking about something with 99% mortality. We've got viruses that are effectively 100% lethal, but something that if it's introduced into a population of whatever organism hosts it, would successfully spread to and wipe out 99% of that host population. I can't think of one. That doesn't mean it doesn't exist. But
only in the movies.
I think
that would be the way to ask the
way.
question. I think. I think the issue. Yeah, exactly. It's these viruses have co-evolved with hosts, and wiping out 99% of your host population is not adaptive.
No, the example is the rabbit control in
I was
Australia,
just saying about
right?
that. That's right.
Yeah.
You put a virus in which is usually lethal, and then within a year, the rabbit in the virus has mutated, so it's not 100% anymore.
Right.
Exactly.
Right.
So I don't think there is any such virus, nor will there ever be, for basic evolutionary reasons.
Right.
Good questions.
Good questions.
Yeah.
I like his bit about if understanding that the latency in an HIV infection would, if it were more readily transmissible, would make that really devastating because you don't notice it for 10 years. So people are passing it around for 10 years before it really strikes.
But even
if such a virus could arise, I would predict that it already would have and would have spread through the entire human population probably very early in our history.
Right.
But HIV is not 100% lethal by any means. It varies in many factors regulate the lethality.
It's easy to understand, though, how a computer scientist might think that might happen based on computer viruses, which do shut down 100% of networks sometimes.
Well, they're binary, right?
Yeah, that's right.
Well, they're binary.
And there's no response. There's no response to the viral.
And they're also attacking a clonal population.
Correct. That's exactly right.
And we are not clonal.
We are not clonal.
But you do have that in viruses, though. You do have, if someone writes a virus that attacks a PC, it doesn't attack the Mac. So you would have, basically, it would kill off a population, and then we'd have a surviving population.
Yeah.
And in fact, in most cases, it'll only target particular versions of the PC operating system or whatever operating system it targets.
We can't even create a 100% lethal virus, no matter what we do.
The next one's from John, who writes, James, sorry. I wrote the wrong name here. James, hey doctors. After reading this article, I immediately thought of TWiV. Now it looks like there is hope to combine my field of cytogenetics with your field of virology. James is a cytogeneticist. He's written to us before. And this article is a Times article entitled "A Tool Gives a New View, Virus Level of the World." It's about a new kind of optical microscope that is quite powerful. It's optical and it can see viruses. So normally you need electron microscopes, which use electrons. This uses light and can see viruses.
It's basically a regular old light microscope that looks through nanospheres that are, basically like nano magnifiers that sit on top of the sample. They got in the original article, they got a really cool figure of this with the objective, basically, these nanoparticles, nanospheres sitting between the microscope objective and the sample. So I think of it as like one of those little desk magnifiers.
Yep.
Those little crystals you got, if you look through those, it magnifies stuff. So you're sitting between the microscope and the sample, and so you get an extra boost out of it. What a clever idea.
Yeah.
All right, James, thanks for that. James writes he looks forward every Monday for a new episode. Great. The next one is from Shama, who writes, I found your podcast while browsing through iTunes, and I have to say I'm hooked. I have the most boring job, but I get to listen to my MP3 player. I have nothing to do with the medical field, so some of the stuff is way over my head, but it's fun to learn about viruses, especially the freaky ones. I was wondering if there have been any studies looking at HIV, generic drugs, and resistance, specifically if generic drugs lead to resistance faster. While the FDA and drug manufacturers say generic and name brand are bioequivalent, I have my doubts. I take Zyrtec for allergies and have tried every store brand I could, but within 3 days I'm feeling horrible and have to switch back to the expensive name brand. Since the generics seem not to work for me, I was wondering if the same could be true for generic HIV drugs. While there are only a few generics in the U.S., third world countries count on them to keep costs low. Thanks, and thank you for a wonderful podcast.
Great question. I love this.
Excellent
and I'm hoping
question.
that Al can answer this for us.
Yeah, I'm not touching this with a 10-foot pole, Rich.
No, you don't have any insight into potential differences between generic and name brand drugs?
My wife is absolutely emphatic that there is a huge difference. I'll be honest with you. When the hospital, when they buy their drugs, it's the cheapest vendor. So not only don't we have the name brand, but we have the most inexpensive of the generic brands, because that's basically the way the hospitals stay alive. So we're constantly switching from one maker to another for generic drugs, Vibramycin, something along those lines. Don't see a bit of difference. We really don't. And a lot of people claim that there is a difference. The only thing I can tell you is there was a huge study by one of the manufacturers of Synthroid, which is a synthetic thyroid hormone, and they tried to prove that the generic brand was not as good as their brand. You could measure actual levels in the blood, and they had a very large study, and it proved that there was no difference. And then there was a big ethical to-do about it, because then they tried to suppress the data from the study.
I remember that.
Yeah, that went on for a while. But to the best of my knowledge, I think scientifically you can't prove it.
So
there's a raging debate about this with biologic drugs now, where there is actually an argument that a generic copy of, say, an antibody drug may turn out to be slightly different than the branded original. But in the case of small molecule drugs, the evidence that I've seen so far is that these are equivalent in blinded studies, and that may be part of the problem here. That if you go to the store and you buy a generic and you're not expecting it to work as well as the branded, you may not have it work as well as the branded drug. Mm-hmm. Placebo effect is real. People like to say, oh, well, that you mean it's all in their heads. No, placebo effect is a real documented effect. We don't understand all aspects of it, but if people believe that they're taking a generic, you may see less of a response.
So here's my thought. Antiviral drugs have to be 100% effective at blocking viral replication. If you have anything less, you will get resistance. These other drugs, allergies, don't have to block whatever the target is 100% to have a therapeutic effect.
Right.
So it could be that the generics are slightly less active, and therefore there's some people who don't respond as readily as others. So Zyrtec probably inhibits whatever target, say 30 or 40%, and that's enough to give you a clinical result.
Sure.
But you can't have that with antivirals. It has to be 100%.
That's actually a very good observation, because there you would see a big difference.
Right.
Yeah.
All right, let's do just one more brief one. I've picked one of the ones from the bottom here from Sarah, and she writes, I would totally buy a TWiV t-shirt, mug, or tote bag that said, does a virus shift in the woods?
Well, you got to put that in the store.
I'm
Vincent.
going to put that in the Cafe Press store, because that was the title of an old episode, and that was Alan's title. And
That's right.
Sarah, you are absolutely right. We will do that. We'll put a little TWiV logo and Does a Virus Shift in the Woods, and they will sell like hotcakes.
I may have to get one.
I may have to get one.
I think we'll all have to wear it every time we're on the air.
Would you wear one, Destiny?
I would wear one.
All right.
Buy one.
Look at that.
Excellent. All right, let's do some picks of the week. Let's start with Al.
All right, I've actually got two. So
That's fine.
Since I don't get to be on here much, so I'm gonna. The first is you've got to be a nerd and a geek growing up to appreciate this one. But there's a book by the name of a guy by the name of James Kalios. I'm probably butchering his name. He's a physics professor in Minnesota, and it's called The Physics of Superheroes. I don't know if you've ever seen it.
Oh.
It's a great book where he uses like the comic book superheroes, Spider-Man and the Flash and whatnot, to teach physics. And it's a wonderfully humorous and entertaining book. And he's a pretty clever guy. If you go to his website, there's a couple video clips of some of his lectures where he talks about how fast the Flash would have to run and if he's going to actually run across water and those types of things. So it's got nothing at all to do with biology, but it's a pretty cool book.
Nice.
It's great. This is all about teaching science. This is terrific.
Yes,
That's right.
Yep.
That's right.
Excellent.
So it's pretty clever in that respect, and having been the type of kid who waited at the corner store for the latest issue of Spider-Man, it kind of brings back memories to me.
I hope you saved all your issues. You'll be a rich man right now.
Yeah, I wish I would have. Dickson, they were under the bed in the box and thrown out. So
Yeah, I don't know what happened to mine either, but they're gone now.
The other is a program that it's a journal watch program that I actually subscribe to called NKT Watch, and Vincent put the link up there. And what it is it searches, and I think it only does PubMed, all the PubMed articles, but you put in certain keywords that you want to look for. So if you were interested in poliovirus, you would just put poliovirus in there. And anytime an article is abstracted in PubMed that's got your keywords in it, it will once a day it sends you an email that lists those articles and their links. You click on the link and it takes you directly to PubMed to that abstract, and then you can do whatever you want with the abstract. Which is it's actually kind of nice because each day I'll get an email from these guys with about 6 or 7 articles on the keywords that I search on, and it's very, very nice at keeping you up to speed on what's going on in your field.
Right.
I love this quote. If physicians would read 2 articles per day out of the 6 million medical articles published annually, in 1 year they would fall 82 centuries behind in their reading.
Yep.
Amazing. So are you 82 centuries behind, Al?
Well, it just goes to my original comment, how easy it is to get something published in the medical literature.
Cool. Thanks, Al. That's great.
You're welcome.
Alan, what do you have?
I have a short YouTube video that I saw just about a week ago, I think. And this is actually from a talk that Neil deGrasse Tyson gave someplace a couple of years ago. But I just came across the video recently, and it is just a 10-minute, he gets a question from the audience about whether he believes in UFOs. And he gives an absolutely brilliant synopsis of science and pseudoscience, the difference between the two, and how science works. And it's, it obviously is not exhaustive, but it's just, it's a really good, and if you've never heard Tyson speak, he's an outstanding speaker.
Great. He's great.
And he just, lays it out and says, this is the deal. And it's a really good use of 10 minutes of your time.
Yeah, I watched this. I had not seen him speak before. I watched this, and I agree. It's absolutely terrific. It's great. I had
the pleasure of having dinner with him when he first took that job, because I'm a good friend of the former head of the astronomy department at Columbia, who's since moved on, unfortunately. But he invited me to dinner, and along with his wife, and here he was sitting there as big as life, and just regaled us with all of his astronomy stories. None of us got the chance to say anything because we wanted to hear what he had to say, so he was just great.
Dickson, you could tell parasite stories.
I could. I actually do that on TWiV.
Yes. And you have a lot of people listening.
Well, that's great. I'm pleased to hear that.
Rich, what do you have?
I'm looking for it here. What happened to it?
I got it.
Yeah. Oh, here it is. Wait a minute. Not yet.
Yep, it's right there.
What the heck happened to it?
It's in the links.
Yeah, I know. But okay, so I ran across this. There it is twice. Okay, so I ran across this. I don't know how. I just kind of stumbled across this. It's a blog that's, I guess it's a couple of years old, or not even quite that. I figured you would know about this, Alan. It's called Retraction Watch. And here's two guys, Adam Marcus and Ivan Oronsky, who are basically journalists.
Yeah, Ivan, I actually have worked with Ivan before.
Okay. Who basically scan the literature for articles that get retracted. And write this blog on individual articles or a series of articles that get retracted. And sort of talk about, why they were retracted, how the retraction was handled, et cetera, et cetera. And it's a very interesting insight into, I don't know, a sort of a weird side of science. And I thought it was pretty entertaining.
Nice.
I don't want to be on this blog.
No.
Elvin Cabot, if he had been on our show, he was a great immunologist at Columbia, and I knew him pretty well. One of his favorite pseudo journals was called Acta Retracta.
Yeah, Acta Retracta. That's a good one. Hey, that was in that little music thing that the guys put together for TWiV, Acta Retracta.
That's right.
They were quoting you, Dickson.
Were they? I'm
looking at one of the comments here on one of the posts, and they're talking about fabrication of data by a graduate student at Columbia. Wow.
I like this title, Retractile Dysfunction.
Yes.
That's a good one.
Author says journal yanked paper linking Viagra Cialis to vision problems after legal threats.
They had one of, I think it was about a month ago, they documented the first chain retraction.
That's good. So it's amusing, too.
A paper was retracted because the data on which it was based had been retracted.
Oh, okay.
I mean, like one paper was retracted, and then as a result, some researchers who'd built on that research decided they needed to retract their work as well.
It's a problem with meta-analysis.
Yes.
Who is next? What's his name? Dickson.
Yeah, that guy in New Jersey. The other guy in New Jersey.
Dickson, do you have a pick for us?
I do, and it's a kind of a fun thing. It's got fun in the title. It's called Fibonacci Fun, and it's a book about fascinating activities with intriguing numbers. And it's a great way of getting kids interested in science by showing them the patterns that nature assumes using the least path of resistance to manufacture shapes of things. And most of the flowers that you see grow that way. But Fibonacci figures are just fascinating in themselves. It's sort of the golden spiral that the Greeks admired, and it's got lots of examples of that. But the book is for kids, but it's probably meant for adults as well, because I enjoy it. And I enjoy all of these Fibonacci iterations. I've become almost obsessed with collecting pictures of spirals because I used to work on a worm called Trichinella spiralis. So that's where this comes from, basically. And it's amazing how many different things out there follow this simple formula.
Cool. Nice. Thank you, Dickson.
So if you're not aware of Fibonacci, this is a great way to get it.
I am not aware of it, but I just Googled Fibonacci and looked under images.
You'll love this, Rich.
Okay, and you get an idea.
My guess is that some viruses must follow this as a path of a self-assembly.
Yeah, Fibonacci numbers are actually really handy if you want to just kind of distract yourself for a few minutes and see how many Fibonacci numbers you can count up to.
Exactly.
Destiny, do you want to make a pick?
Sure. I finished reading a book. I don't know if you guys picked it before, but it's called Microcosm by Carl Zimmer, and is all about E. coli, which is a lot more interesting than you might think at first. I believe in the book he says it's the second most common studied organism, ourself being first. And it's a lot of comparisons between what we know he mentions this whole phrase, what's true for the E. coli is true for the elephant. So it talks about things we've learned from E. coli, DNA stuff, talks about viruses of E. coli, the which is really, really interesting. I would recommend it.
Microcosm, yeah. Great, that's a good one. We have a new book by Carl Zimmer on viruses, just came out, and I'm going to try and get him on to talk about it in the near future.
I'm sure he'll agree.
You think so, Dickson?
I do, actually. I've talked with him many times in the past, and he's verbose and very informative.
Very good. Just like you, Dickson.
No, Vince, please.
I'm your buddy, don't worry. All right, my pick is a perspective article in a journal called Frontiers in Cellular and Infection Microbiology. It's called The Intestinal Microbiota and Viral Susceptibility. So we've talked, and a number of listeners have asked, what does we know about the intestinal microbiota. What about viral microbiota there? And does the microbiota of your intestine infect what viruses you get infected with? So this is a review. It's open access, so everyone can read it. And it just goes over what we know. And it's clearly a beginning field, and it's developing. But it's quite interesting to read about it. So I encourage you to look at it. It's a scientific article. It's not easy, but it is accessible, and I think that's a good part of it, that everyone can read it. By Julie Pfeiffer and Justin Sonnenberg.
Very cool.
And we also have a listener pick of the week. It's from Jim, our buddy in Virginia. He picks the movie Extraordinary Measures, which I have never seen.
Nor I.
He said, I just saw this 2010 movie concerned with the genetic Pompe disease and think it embodies the three key facets of your profession: research, commercialization, and prioritization. It stars Brendan Fraser, who handles the commercialization and prioritization parts, and Harrison Ford, who handles the research end. Mm-hmm. See if you agree that it captures quite well the essence of each aspect. Would Maurice Hilleman be Harrison Ford, or one of the players in the big pharma company that buys his research?
Definitely Harrison Ford.
Thank you, Jim. That's cool.
Is a penchant for four-letter words? Is that what you're saying?
Harrison Ford could play a prickly character, and that's who you would need for that role.
Rich, what do you got here? You got a little note. Am I supposed to read that?
Yeah. No, you don't have to read it. Well, the original clinical trial for the drug for the therapy
in this movie
that was highlighted in the movie was designed by a guy here in UF.
Ah, that's good. You can. So
there was a big hoopla, as you can imagine.
Yeah, great.
And all these guys went to the opening in L.A., and it was a big deal. It was fun.
Cool.
Very good. All right, that will do it for TWiV in the ER. I want
to make one comment, and that is that getting a physician or physicians and basic scientists together in a situation like this is terrific.
This was great.
Yes.
Absolutely.
Both sides of the equation.
Yeah.
We do this on a monthly basis here. We get the infectious disease docs together with the basic scientists and go over our particular case. And it's fascinating for me, and I think instructive for everybody, and it's something we ought to do more often. It's really terrific.
Hear, hear.
But I think you guys underestimate how much we rely on you guys to get anything done. So it's been I tell you, I've listened to you since TWiV 1, and it's a real joy to have gotten a chance to hang with you guys for an afternoon.
Well, we feel the same.
Yeah. Well, Al, we've come back again because when we have papers with clinical aspects, you can come on and help us talk about it.
Either Rich can bring some of his infectious disease guys, or I'll grab some of our infectious disease guys to hang out with you.
We could have a grand rounds.
That would be fun.
Perfect.
I just want to tell everyone that we recently passed our 1 millionth download of TWiV.
Congratulations.
So thanks to everybody. And that's the last milestone we will mention until 10 million.
That's right.
We did 100,000, 500,000.
We go
1
by
million.
log phase here.
So that's pretty. Some sites get 1 million downloads a day, but for a virology podcast, I think that's pretty good. So we have great listeners. So thanks to all of you.
Marvelous.
Of course, you can find TWiV in many places: at iTunes, at the Zune Marketplace. You can also stream it to your iPhone or Android device using the Microbe World app at microbeworld.org/app. You can play the episodes also at twiv.tv, where we have show notes and everything else. If you do like it and you're new to TWiV, please leave a review on iTunes. It helps us to stay near the top of the Science Podcast list. And, of course, send us your questions and comments to twiv@twiv.tv. Al Sacchetti is in the emergency room in Camden, New Jersey. What's the name of your hospital again?
It's Our Lady of Lourdes Medical Center.
Our Lady of Lourdes. Al, great to have you. Thanks so much.
Thank you very much for the invite, guys.
Great. Dickson Despommier, verticalfarm.com. You sound very good over there, Dickson.
I feel great.
Now,
I'm glad I sound great.
All right. Thank you for Skyping in this afternoon.
Yep.
Rich Condit, University of Florida, Gainesville. Thanks, Rich.
You're quite welcome. Good fun as always.
And Alan Dove is at alandove.com.
Always a pleasure.
Destiny, thanks for coming in.
Thanks for having me.
So you're heading
nice.
in the fall to UC Davis.
I am.
And you're going to keep listening to TWiV, I guess?
Of course.
All right. Well, you can send in questions anytime. And if we're ever out at Davis doing a live TWiV,
You have to come by and
better
stop.
come by.
Good luck, Destiny. Nice talking to you.
You too.
Yep.
Take care.
I'm Vincent Racaniello, and you can find me at virology.ws. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.